Dr. Henri tell you, it's a little hard to prepare a talk like this because the complication rate should be extremely low for this procedure, I think in an experienced operator's hands. When we talk about renal artery stenting, I think it's important to remember that there are some guidelines as far as indications for renal stenting are concerned, and despite what our personal opinions may be for those of us who are involved with renal artery stenting, we have to remember that the guidelines, when we look at hypertension, preservation of renal function, and treatment of heart failure, are very well stated, and the only class 1 indication that we have at present is for patients with congestive heart failure. What's been mentioned earlier is that when we perform renal artery revascularization, we see that there's a change in the serum creatinine as a surrogate of renal function. And what we see is that negative slope or decline in renal function over time is altered after stents are placed. And there may be improvement in the renal function after the stent is deployed. Either the renal function may be stabilized. This comprises that 70% of patients that Dr. Henri mentioned. And then in other patients, the rate of deterioration in the renal function or that slope actually declines. Regardless, when we look at pooled data, it's still apparent that a significant number of patients have a deterioration in their renal function after renal artery stenting. Some of the patients are improved, but I think at least 50% of the patients being stabilized is a good outcome. The stenting technique, as was described earlier, as far as access and equipment is concerned, is quite simple in that once you have a protocol for doing this procedure, you really shouldn't deviate from that protocol because that's the reason you will have very high technical success, and that's the reason you will have a very low complication rate because you follow that same recipe. And when you follow a recipe, one of the things that happens is that you don't omit things. So strict adherence to the recipe. And that includes access site selection, either femoral, radial, or brachial, with some of the longer guiding catheters and balloons and stent delivery systems that we have nowadays. The brachial approach is rarely used in my institution, so the majority of cases are performed from the femoral or radial approach. You can use a guiding catheter or a sheath. 014 guide wire. When we started doing renal stenting years ago, we used 035 wires. Some operators still use 018 wires. I would encourage you to use 014 guide wires. And certainly we try to avoid the hydrophilic wires because those wires are difficult to control, and the risk of perforation of the renal parenchyma is much higher. We have dedicated stents for renal artery stenting, and then embolic protection devices. There was a discussion in the previous session about embolic protection devices, and I think suffice it to say is that the embolic protection devices and the renal anatomy for the majority of patients don't quite match, meaning their early bifurcations or short landing zones, which make it impossible to use embolic protection, even if you were desirous to do that. The stenting technique requires diagnostic angiography. This can be a CTA performed prior to taking the patient to the vascular lab. Usually when I perform the angiography, I use an internal mammary artery catheter if it's from the femoral approach, or a multi-purpose catheter from the radial approach. A lot of operators will use the JR4 that they use to do the coronary angiography, and then use that same catheter to do the renal angiography. I think for the majority of patients, the curve on the JR4 is not favorable for most renal arteries, and I would either use an IMA catheter to perform my right coronary angiography and renal angiography, as opposed to using the right Judkins catheter to perform both. You need to select the appropriate patient, and that's according to the guidelines. That's according to the patient sort of a substrate comorbidities. Quantitative angiography, the points that were made about not overdilating cannot be overemphasized, and if you really want to avoid complications, you need to perform quantitative angiography. Your visual estimate of the renal artery is fraught with error, and the majority of times what you estimate will be much larger than what the artery size actually is. So when I perform renal angioplasty and stenting, 100% of the time I do quantitative angiography. Hemodynamic assessment, if necessary, certainly if you have a 99% stenosis, I think the hemodynamics becomes a moot point. But hemodynamic assessment is necessary, and part of the reason that the trials that were mentioned earlier by members of the panel were equivocable or showed that there was no difference between stenting or endovascular therapy and medical therapy was because of the patients that were included in those trials. Those patients had non-significant angiographic stenosis, and there was no hemodynamic assessment of the degree of stenosis in those trials. And so consequently, if you take patients that don't have renal ischemia and put them in these trials, then it doesn't take a rocket scientist to realize that the results of those trials have already been determined before you even conduct the trial. And so the errors that were made in the design of those trials followed through to the results, and that's not a big surprise. You want to cross with the wire. We talked about the direct approach, coaxial, or the no-touch approach. I think all of these require a little bit of expertise and a little bit of experience. So I think whichever technique you use, you want to become very facile with that technique and try to reproduce it each time. Distal embolic protection we talked about. And then I think pre-dilating helps you to determine whether the lesion is distensible. It also gives you a good idea of whether or not your quantitative angiography was accurate and you did appropriately size the vessel. And then we stent. This representative panel shows from a radial approach that a stent has been placed across a proximal stenosis, and then the result after balloon expansion on the right-hand side. Now, as I mentioned to you as I started off, it's very difficult to find cases of complications, so I had to sort of go through the archives to find cases of complications that happened in my institution. And this was one of my cases from years ago, but it emphasizes some of the points that I think are important for you as you begin your career with renal artery stenting. This is a baseline angiogram, and I think most of you would say that this is a very high-grade stenosis, and certainly this is someone who may benefit from having renal artery stenting. In hindsight, when you look at this, you can see the aorta or the calcification in the aorta, and you can also see very dense calcification around the origin or the ostium of this artery, and that's going to be important as we watch this case. So this is with balloon angioplasty, and you can see that there's still a significant waste in the middle portion of the balloon. And so after angioplasty, the stent is positioned. And again, we try to make sure that the stent actually does not completely go inside the renal artery, and that part of the stent is inside the aorta so that it takes care of that aortoosteal plaque, which is very common with this disease process. And so once we're sure that the stent is adequately positioned, and part of the positioning has to do with looking at the perpendicular aorta distal, because the rest of the aorta in the renal artery gets distorted by the combination of a balloon, a stent, and a wire. But the most reliable landmark is this aorta distal to the renal ostium. So this looks like a fairly favorable position to position the stent. Stents deployed, post-dilated simply by just removing the balloon so that it doesn't stick out the distal end of the stent and inflating it again. And then this is the result after the stent. So this was before we had the smaller covered stents that most of you have in your laboratories nowadays, which is a blessing. And if you're doing renal artery stenting or if you're doing endovascular procedures, you need to have covered stents in the laboratory on the shelf. We had covered stents, but this was many years ago, and the only covered stent I had was a wall graft. So what it required me to do was to place another guiding catheter in through the contralateral femoral artery. At the same time, the balloon was inflated to stop the bleeding. So I think the trick is that they're bleeding. You have to stop the bleeding. So the balloon's inflated. We get access on the other side, actually deflate the balloon, pass another wire, reinflate the balloon. So now you can see two guiding catheters. Here's the wall graft coming up through the other guiding catheter. This was all we had back then, so it's a very long graft being deployed. The balloon was removed in the other wire. Then this was post-dilated, and that was the result. Now, with most of these covered grafts, the initial angiogram you perform, they're still somewhat porous, so you will see some leakage. But here's the final angiogram, and then the patient came to the catheterization laboratory for angiography sometime in 2010. And you can see that that stent remained patent. We had that typical sort of self-expanding stent appearance where the stent seems to be larger than the actual diameter of the vessel. So I think the lessons with this type of case is that if you have heavy calcification, then you have a risk of rupture. So you want to undersize, as Dr. Henry had mentioned to you earlier, because you can always make it bigger. You want to perform quantitative angiography, as we did, have covered stents in your lab. Perform angiography after you predilate and after you stent, because if you don't, then you don't recognize this problem, and it can be a catastrophe. And then don't panic. So if you're bleeding, then blow up the balloon, and you can stop the bleeding. If you don't know what else to do after that, then that's fine. You can blow up the balloon. You can even make a phone call and call one of your friends and get some advice, but don't panic. This next case is, again, someone who obviously is a good candidate for renal artery stenting. It's a solitary kidney in a patient with poorly controlled hypertension and renal insufficiency. Predilatation, this is a case where embolic protection was being used. And now you can see after predilatation, this large thrombus in the distal renal artery. A aspiration catheter, the Pronto, was advanced over the embolic protection device. And there was a decrease in the amount of thrombus, but still a considerable amount of thrombus left in the vessel. So what was done next was that the proximal portion was stented because they were unable to get the guiding catheter back into the artery. So we stent the proximal artery. Once the proximal artery was stented, the guiding catheter was able to be advanced into the vessel. So why do you want to do that? Because it has a much larger lumen, and with the guiding catheter, they were able to aspirate through the guide while the embolic protection device is still in to remove the thrombus. So the tip of the guide is actually in the renal artery now through the stent. It wouldn't go ordinarily. You wouldn't want to stent and then stick your guide through, but we couldn't get the guiding catheter to advance. So once that was performed, aspiration, and then post-aspiration, there's some debris still in the filter. The Pronto was advanced again, stent post-dilated, and then the final angiogram. Thank you very much.
Thank you very much, sir. My question is, what are the surgical indication in a solitary kidney or in a transplant kidney? Surgical indication. Where do you suggest surgery, auto-transplantation?
When do I recommend?
In a solitary kidney with renal artery stenosis or a renal transplant patient, we see most of the patient with renal artery stenosis post-transplant. When you suggest surgical correction?
When do I suggest that they get surgery? I think, at least in the U.S., the surgical revascularization for kidneys is becoming a lost art. Like a lot of traditional surgical procedures, there's not a lot of expertise to do that. So most of these patients, and with the changes in the technology, are now amenable to having an endovascular procedure. Even if it's a transplanted kidney, the majority of those patients will have a endovascular procedure. Now, rarely some of the transplant kidneys, depending on where the transplant was performed, whether it was done with a long piece of Gore-Tex, those patients can have surgical revision, but for the most part, revascularization of kidneys using traditional surgical techniques is not done that commonly anymore.
What are your personal results in renal transplant patients with renal artery stenosis of endovascular procedures?
Renal artery stenosis, how many have I done?
In transplant patients, yeah.
Oh, in transplant patients? Probably 20 or so.
So the outcome is good of endovascular procedures?
The outcomes have been fine. But, we have, as Dr. Henry was saying, that when you look through the literature, whenever you see technical success rates, some of the early literature, like some of the early Dutch literature, the technical success rate was 88%. I think any technical success, if I read an abstract and the technical success is less than 98, 99%, I don't read the manuscript. I mean, because it's obviously going to be a very skewed result. The technical success should be 100% for the majority of publications.
In patients who had thrombus, would you recommend some intra-arterial thrombolysis to minimize the distal obstructions?
In the renal arteries, yeah, that's what I'm hesitating. It's a tough question. I've had patients, the typical patient that has thrombus is the patient that embolized either from an aneurysm or, rarely, someone who has atrial fibrillation embolizes to their kidney. Usually they'll embolize their mesenterics if they embolize viscera, but sometimes they can embolize their kidneys. The emboli from the heart.
Just like this case that you're showing.
Yeah, in a case like this, that would have been a possibility. It's a little bit longer as far as the treatment is concerned, and this seemed to be mechanical, directly related to instrumenting the artery and thrombus forming, and it was easily approached with a mechanical solution. If the mechanical solution doesn't work, then I think you can use thrombolysis.
Some bits might have gone distal, isn't it?
Yeah, I think with the whole idea, every time we intervene in a kidney, that there's probably something that goes distally. In this particular case, even with the embolic protection device, and I think that emphasized some of the issues that we have with the protection devices. You see that it tends to go into one branch, and there are other parts of the kidney that aren't being protected. I think once the emboli have already traveled to the kidney, becomes another issue. It's a little suspect because if you look at some of the results of, say, Dr. Cooper in the U.S., when he used a particular type of embolic protection device and coupled that with the use of abciximab or a 2B3A inhibitor, then that group of patients did better than the group that just had the filter without the 2B3A inhibitor or the 2B3A inhibitor without the filter. So there was something, quote, magical about that combination. That implies that there is a mechanical portion that's refractory to pharmacotherapy, and there's a pharmacotherapy portion of it that defies the mechanical part of it. So it's probably a combination.
Do you find no reflow kind of situation, just like as you see in coronaries? Do you find no reflow in the renal system?
Yeah, you don't see that, but I think we're not as accustomed, and if you look through the literature, people are not accustomed to looking at the renal flow or looking at the count. I mean, we're focused on that major artery, and we're not looking at the sort of the microvasculature of the kidney, which we can do, and we can look at the sort of the renal counts and see how long it takes for the contrast to sort of clear from the kidney. It gives you an idea of what the microvascular flow is. I'm not aware of any references where they looked at that pre and post. But it's an interesting question, though.
Okay. I'd like to thank the speaker calling. With the permission of the expert panel, we'll move on to the last presentation that features Dr. A. Srinivas Kumar.